In a world like this, there's obviously a distortion potentially because of insurance and things in the choices that people make in terms of how much health care to get. Should I get my knee replaced? Should I, take my kid to the doctor when he has the sniffles, whatever it is. I mean, all those margins where we could spend a little bit more. And obviously, if they told me it was going to cost $400 to take my kid to the doctor, I'd probably be a little more reluctant to take him if they tell me I got to pay a $10 copay. Yeah. And, the big difference, 400 versus 10.
For sure.
So that's part of it. But what about the types of treatments that are developed? And I know this is another area you're interested in. Do we develop more expensive treatments because we know insurance companies will then be induced by the suppliers, in this case doctors, to give people access to those treatments, even if we could have had almost as good a treatment for substantially less money? Is there a tendency to distort innovation as well?
I think there is, but I think it's more complicated than people within the health economic community think. So I think the standard explanation, which is I think advanced by folks like titans in the field like Joseph Newhouse and Bert Weisbrod, is this idea that because insurance exists, innovators, drug companies and the like know that there's going to be a lot of demand for their products. And so they innovate. Sometimes that innovation turns out to be productive, like a highly active antiretroviral therapy for HIV. But other time it doesn't. It's a proton beam therapy. But because there's insurance, people still buy that. And so the concern is that, and then this cycle repeats itself. And so the concern is insurance begets innovation, which then begets expenditure even on things that are not productive because they're low cost.
Because the people aren't paying the cost. There may be high cost to society, but for the guy making the decision, they're low cost.
Exactly. Now, one of the problems with that is we only have kind of indirect evidence of this. We know that, for example, market size affects innovation. We know that not everything that comes out is cost effective, and we do spend some money on things that are not cost effective. People have talked about that. But we don't have a really good sense of how important, how big this effect is, how much inefficiency there actually is. And then there are other small things that come out that suggest, insurance can have some positive benefits on innovation. A paper I particularly like and that's underappreciated is by Dryas Lakdawala and Neeraj Sood. And they point out that the way that we get innovation typically is through patents. And if you look at the literature on innovation, the standard trade-off with patents is there's dynamic efficiency, that means that patents, giving people monopoly right to sell a new drug, encourages them to do the innovation required to get the drug in the first place. It encourages innovation. But then there's something called static inefficiency. What does that mean? That means that the company that's the monopolist in selling the drug sells at a monopoly price rather than a competitive price, and therefore a number of consumers aren't able to access, purchase, or afford the drug. So there's less consumption than would be optimal.
So let me just try to make sure I understand or people understand. So the idea would be this. I give a drug patent protection. Because it has patent protection, what that means is for some period of time, the person who developed that product and got it patented will be the only seller in the market. Nobody can make a competing drug that is exactly the same. In other words, you can't have generic knockoffs come out day one. Yeah. There's a time period over which he'll be the only seller. Mm-hmm. Being the only seller, this is where you talked about monopoly, that allows me to charge a higher price than if I had to worry about competing with these generics. We do that recognizing that, boy, it'd be great to get low prices, but if we got low prices, there wouldn't be so much incentive to invest in the first place. So we give him that benefit of a temporary monopoly that allows him to reap some profits on his innovation. And what we give up there is the low prices we could have had. So there's a trade-off. The longer we make the exclusivity period, the more innovation hopefully we would get, but the longer we're going to have to wait to get the low prices that come from competition.
Exactly, and that's the standard view of patents. But one of the things that Lakdawala and Sood pointed out was insurance kind of breaks that. In the following sense, with insurance, you have a situation where the insurance pays to the drug company a high price, but the consumer purchasing the drug pays a low price. They pay their copay, which is very close to the competitive price, but the drug company is getting monopoly price. And what that means is you both get the rents that the drug company needs to encourage it to innovate, but also consumers don't underconsume because they're paying the copay. And really interesting, I think this is an underappreciated fact, is that when drugs go off patent, that is to say, when the monopoly ends for drug companies, you would think that in fact drug consumption should rise because all these generic companies enter, prices fall, but it's not the case. In fact, it's very stable before and after, which is very consistent with this idea that because of insurance, consumers face the competitive price in the first place. So I think that's an example of one of the many types of situations where insurance is having these other effects that offset the overconsumption effect that we were talking about, that the Joe Newhouses and the Burt Weisbrods of the world talk about. So
but drugs are very different than other types of therapies. And this is an issue I'd like to we can touch on a little bit here, because the key thing about drugs, and this is mostly applies to chemical entities as opposed to biologics, maybe in a different category, is they typically cost a lot of money to develop, because you have to find a compound, you have to check that it's safe, you have to check that it's efficacious. And so creating the thing in the first place is usually pretty expensive, but you actually look at the cost of making each individual pill, that's incredibly low, which is why you might be worried that under the typical patent scenario, we'd have a big distortion. We'd have way too little consumption because we should use a lot of this stuff that's really cheap. And your point is, and Dr. Walla's point is really, because of insurance, actually we get the best of both worlds. We get that consumption associated with a low incremental cost, but still get the rents there to induce innovation in the first place.
Exactly.
But other forms of treatment, so for example, going to see the doctor or having surgery, those aren't they're subject to a very different kind of economics. If I want to do twice as many customers, I probably need twice as much resources, essentially. I need an operating room, I need an extra doctor, I need an extra hospital bed. How does that fit in with healthcare and healthcare spending? I know drug consumption has gone way up. We've switched a lot to drugs as the market has expanded. That we do know.
So a few things on that. The first is I think people focus on drugs, but as a percentage of overall healthcare spending, may not be as large as people think. If you look at the national...
It's grown a lot. But
it's grown, but still around 15%, 20%.
But it was like 5% in 1960s or something.
That's
like
right.
that. It's gone up a lot. And one question I have for you is, given that drug therapies have this, what is called high fixed cost, low incremental cost profile to them, and given that the market's going to continue to grow worldwide for healthcare, I mean, it just, even if we think that it just goes up proportionally with income, as people get richer in China and richer in India and around the world, it's an enormous growth in the healthcare market. Do you see a switch toward more of these fixed cost therapies, which would seem to have a huge advantage in a growing market, relative to building out more and more hospitals with more and more doctors and more? It would seem to me, as an economist, I would expect that to be a big part of the future of medicine, would be these taking advantage of these economies of scale in a growing world market.
For sure. In fact, in the United States, we have fantastic infrastructure. And we can deliver new non-drug therapies, whether it's surgeries and the like. But if you go to a developing country, so I do a lot of work on the healthcare system in India, you have far fewer medical facilities per capita. It's a very difficult problem to actually reach rural areas. In that context, pill delivery or injection delivery is much easier than trying to say we want to spread a new form of surgery or
inpatient treatment.
Yeah, that's exactly right. It's also very hard to make sure, even if you have the people, it's very hard to make sure that people are doing the same thing and doing it correctly. That uniformity is difficult to achieve. And so again, this is why drugs, which you can maybe control the quality of at the factory, are quite helpful. And by the way, not a point that's unique to healthcare. You'll see this also for education and other services. There'll be, interestingly, even though they're rich in labor, a lot of the solutions you'll see are capital intensive, that are technology intensive, simply because given the weak infrastructure, it's easy to ensure quality that way.
So you would say there is probably more of a future there. I mean, I would say healthcare is going to be a growing industry worldwide. Even if we were to control our growth as a share of GDP, say it stayed at 17.5 for the foreseeable future, it's probably going to rise in these developing countries. I mean, I think there's little question that in India and China, we're going to see more income, and if we see more income, we're going to get more healthcare, likely growing more than proportionally with income, I would suspect.
Yes, I would agree. You take a country like India, again, an area that I know a little bit about. Percentage of GDP spent on healthcare is around 2 to 3%, far lower than other, say, OECD or even some other second world or middle income countries. So I think you'll see a dramatic, faster than rate of income growth, rate of increase in health expenditures. Again, likely focused on drugs, and then a slow shift back as the healthcare infrastructure in these countries is built out and reaches say the OECD level.